class, my name is Kelly Herman, and my part of the presentation regarding our trauma and substance use is the individual treatment, and I focused on EMDR. The assessment screening that I will be using for Stephanie will include a clinical interview or a self-report. During this time, I will obtain a biopsychosocial history that includes a history and current mental health substance abuse treatment, history and current medical concerns, family history of mental health and substance abuse, her current coping strategies, and her community and peer supports. I will also determine whether Stephanie is a good candidate for EMDR. We will identify traumatic experiences that can be targeting for processing. The level of care that I am recommending for Stephanie is an inpatient residential treatment setting. During this time, she will be involved with eye movement desensitization reprocessing therapy, otherwise known as EMDR. EMDR was developed by Francine Shapiro in the early 1990s. It focuses on reprocessing the dysfunctionally stored memories of the traumatic experience, enabling the client to progress through appropriate stages of affect and insight to reach an adaptive resolution regarding critical issues such as personal responsibility, safety in the present, and the availability of choices in the future. It can also help facilitate all aspects of the recovery process, enhancing motivation, addressing and preventing relapse, and enhancing the quality of recovery. The theoretical framework behind EMDR: it is an evidence-based treatment intervention guided by the Adaptive Information Processing Model, otherwise known as AIP. With this model, the standardized procedures and bilateral brain stimulation facilitates entry into an accelerated state in which traumatic experiences can be processed effectively and efficiently. Bilateral and/or focused stimulation is the key aspect of the treatment, and it is achieved by using sounds and taps. The brain has difficulty integrating traumatic memories, connecting them with similar memories and storing them. The stored traumatic memories can lead to maladaptive coping strategies. This is where we often see individuals struggling with trauma using addiction or using substances as a coping strategy. Activating these memories can cause intense anxiety, inappropriate emotional, cognitive, and behavioral responses. The tools used with EMDR include earphones, taps, subjective units of disturbance scale, and validity of cognition scale. While we're working through the different phases of EMDR, oftentimes we need to check in with our clients using a scale from 0 to 10 to describe their feelings and emotions. EMDR is an 8-phase treatment protocol addressing past, present, and future experiences and behaviors. During the first phase, we obtain the client history and identify traumatic experiences and determine whether they are a good candidate for EMDR. During phase 2, called the preparation phase, we explain EMDR, we start to form that therapeutic alliance, and we teach strategies for managing intense feelings. The client is taught containment strategies for managing these intense feelings and helping the client feel more in control. During phase 3, the assessment phase, we target memory that will be processed, and it's identified and assessed. The client is asked to focus on the disturbing image that represents the worst part of the traumatic event and to identify negative beliefs about herself that are rooted in the experience. The therapist then will ask the client to formulate a positive cognition that could replace the negative belief. Next, the client is asked to notice the feelings and body sensations associated with the disturbing memory. At this time, the baseline measurements of reactivity are assessed. During phase 4, desensitization, disturbing experience and present stimuli that trigger the past experience are processed. The client is instructed to hold the disturbing event in her mind with the associated negative belief, feelings, and sensations in her body while focusing on external stimulus. The client is asked to track the therapist's fingers or hand as he moves them back and forth in front of the client's visual field for about 20 to 50 seconds. After each set of bilateral stimulation, the patient is asked what changes she experiences. This is the time that we start to use the rating scales from 0 to 10, and the client can document the changes of the intensity of feelings and body sensations. Phase 5 focuses on installation. In this phase, the client identifies her most desired positive belief about herself. Using bilateral stimulation, the therapist helps the client increase the connection of the new positive cognition with existing positive cognitive networks. The effects can then be generalized with associated neural networks. In phase 6, that's the body scan. The client identifies and is helped to process residual body sensations. Phase 7 focuses on closure. And phase 8, reevaluation, the assessment that occurs at the beginning of each subsequent session. In each new session, the client's psychological state informs the next step. The goal of EMDR treatment is to assist the client in reprocessing and adaptively storing dysfunctionally stored traumatic memories. The next slide here, you can click on this link and you can see a YouTube video of EMDR in practice showing the 8 different phases. The individual treatment plan for Stephanie. Her goals and objectives. The problem is that Stephanie is engaging in risky behaviors and using illegal substances in order to cope with symptoms associated with the trauma. Her long-term goal would be for Stephanie to use appropriate coping skills in order to decrease anxiety associated with triggers from past traumatic events within her life. Her short-term goal would be that she would identify and develop positive coping skills to address anxiety and bodily sensations associated with trauma. And the intervention that we'll be using will be 8 consecutive sessions of EMDR. Problem area 2, Stephanie is unable to identify the symptoms and triggers she is experiencing and encountering due to trauma. Her goal would be to be able to identify the feelings, bodily sensations, and emotions she is experiencing in regards to specific triggers. Her short-term goal would be for her to be able to identify specific triggers within her environment that are causing her distress. And again, the intervention would be 8 consecutive sessions of EMDR and linking Stephanie's symptoms to specific triggers within her environment. Time of sessions. The client must agree to at least 8 consecutive sessions. A lot of times it does take 12 sessions, so you should leave some room in there just in case sessions run longer or there's more things that you need to address. Each session should be 1 hour. Stephanie would benefit from receiving the sessions within a residential inpatient facility due to the risk associated with relapse. Bringing up these traumatic events can cause relapse if she would be out in the community, so it would be safer to do this treatment with her in an inpatient facility. There are many strengths of EMDR. It's a short-term treatment option, as I said, 8 sessions. It's more effective than medication or placebo in decreasing symptoms of PTSD and depression. Many professional associations, government agencies, and major insurance companies have approved EMDR as an effective treatment. A lot of VA facilities are using EMDR to deal with PTSD. It helps trauma survivors regain capacity to live productive lives. It could help prevent violent offending by youth and adults. And this is if somebody is offended, they often perpetrate as they get older, so this could help to prevent that by addressing it. Can be useful during the recovery process, increase clients' access to positive affective states, help the client build a positive support system, obtain emotional stability, and develop self-soothing techniques. The weaknesses of EMDR, ensuring safety for clients engaging their support system outside of treatment. And this is mainly with addiction or substance use, because we can't gauge what their support system would be. But this is also for anybody engaging in EMDR. We want to ensure safety. Insurance coverage, it's mainly covered by private insurance, so it may not be covered by medical assistance. Engaging clients in treatment for 8 sessions. If you're having trouble having your client come to therapy each week, this may not be the right treatment because they need to engage for 8 sessions. It requires significant training for the therapist. This could also be a strength, but it does require a lot of time, 18 didactic hours and 13 supervised hours with a trained clinician. The individual methods of evaluation. I would evaluate Stephanie after completing the 8 sessions, and I would use a self-report. I'd ask her, have we addressed the past, present, and future experiences? How are your traumatic symptoms? Have they decreased? The anxiety, the depression? Have you been able to identify your triggers and your coping skills? Are you able to use them? How are things working for you now that we completed this? I would also give her a self-assessment questionnaire. She may not feel comfortable talking about everything. I would hope at this point she would, but some stuff she might want to put in a questionnaire. So I'd give her a questionnaire to complete. I also think the evaluation of this method needs to continue through studies to address trauma in EMDR and addiction in EMDR. Prognosis. I believe that maintaining Stephanie's treatment to an inpatient residential facility will help in obtaining a good prognosis for identifying triggers and coping skills. However, I feel that the prognosis is fair when returning to her community setting unless changes are made within her support system and environment. A research article that I read was entitled EMDR and Evidence-Based Treatment for Victims of Trauma by Solomon and Hyde. They reported that it was an evidence-based treatment for individuals experiencing PTSD and related psychological disorders. It focuses on reprocessing dysfunctionally stored memories of the traumatic experience. It enables the client to progress through appropriate stages of insight to reach adaptive resolution regarding personal responsibility, safety in the present, and choices in the future. The effectiveness of EMDR was confirmed through at least 16 randomized controlled and 8 non-randomized studies. For example, Vanderkolk and his colleagues compared the efficiency of Prozac, EMDR treatment, and a pill placebo. They found that EMDR was more effective than the medication or placebo in achieving sustained decreases in the symptoms of PTSD and depression. At the 6-month follow-up, 75% of the adult onset trauma survivors were functioning without symptoms compared to none of those in the medication group. Among the adults with child onset trauma, 33% were functioning without symptoms. It's an effective treatment that has brought relief to thousands struggling with the effects of traumatic experiences. Another article that I read was entitled EMDR in the Treatment of Addiction by Zwiebin and Yeary, 2006. They reported that EMDR must be carefully integrated into addiction treatment. The individual safety structures must be in place to protect vulnerable clients. EMDR has been an effective treatment with trauma and warrants additional studies be completed about the effectiveness with substance users. Many of the studies that are completed just involve PTSD and EMDR. But the American Psychological Association has reported that 75% of individuals struggling with trauma are also struggling with substance use. So it would be good to have more studies regarding this. EMDR can be used to target traumatic experiences that trigger cravings. Residential treatment facilities represent a highly desirable setting for EMDR due to the safety structures that are put into place. Outpatient treatment requires that clinician sets a standard of safety for the client and assess stability within the client. In early stages of recovery, it is critical that the client develop resources for maintaining abstinence, such as community resources as AA and NA, and that they tolerate the feelings without drinking or using. And this is a list of the references that I used for my presentation. Thank you all for listening and have a great day.